This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new here, I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We have been coming to you since October of 2016 with these podcast episodes, and now we are trying to review the American Board of Pediatrics Pediatric Hospital Medicine Content Specifications. We are hitting a topic today that I feel genuinely the weakest in as a clinician and as a physician. I know all of you agree there are areas we feel better about, there are areas we don't feel better about. We are going back to our friend rheumatology. We are going to hit our good friend lupus, pediatric systemic lupus erythematosus. We have with us friend of the podcast, Dr. Elaine Cassidy, helping us with this topic today. In case you forgot, Dr. Cassidy is an assistant professor at the University of Pittsburgh in the Department of Pediatrics. She's a board-certified pediatric rheumatologist. She's the associate fellowship director for the Division of Rheumatology, and she's the clinic director for the Division of Rheumatology. So there isn't anybody better to help us with this episode and with this specific topic. Quick reminder before we get right to her, for those of you who are listening, the University of Pittsburgh gives us CME credit for anyone who's listening. All you have to do is click on the link in the description of the podcast below, get a login, answer 5 questions. It's all free, and you can get AMA Category 1 CME credit. We hope you take advantage of it. So without further ado, going into the topic of lupus, Dr. Cassidy, welcome. Thanks for joining us again.
Thank you so much for having me. Very excited to be here. Very excited to talk about another great room topic.
Another great room topic. That's right. Before we get any further, let's do our conflict of interest statements. I have nothing to disclose.
I also have nothing to disclose.
All right. So normally when I do this, we review like 10 papers. This particular topic, there was a couple really good papers. And the first one that I spent days reviewing was the Pediatrics in Review, Pediatric Systemic Lupus Erythematosus, written by Dr. Jennifer Weiss. It's More Than a Positive ANA is the full title. Pediatric SLE, More Than a Positive ANA. Volume 33, number 2, in February of 2012, if you're keeping track at home. So what I liked about this paper in terms of reviewing for lupus, it starts out, they give this very nice description. They call it a chronic, multi-system autoimmune disease characterized by periods of increased disease activity caused by inflammation of the blood vessels and connective tissue. I thought that was a nice kind of overview of a very complex disease.
I agree with you. I think the big thing is multi-system, because sometimes it's hard to know when to think about rheumatic diseases, and multi-system is one of the big things to entertain rheum diseases for.
And then one of the things they mentioned early on, generally again, is that pediatric patients with lupus have a more severe clinical course and more disease activity over time compared with their adult counterparts, which I did not know. I didn't know it was more severe if you got it as a kid.
Yes, and we don't fully understand that, but it's really because of the organ systems involved.
Okay. So we'll get right into the epidemiology. Now, 20% of lupus cases are diagnosed in the first 2 decades of life, they tell us. Pediatric lupus usually presents commonly in post-pubescent females with an average age of onset of 12 years old. They talk about before puberty, the male to female ratio is 1-3, but after puberty, it increases to 1-9 with a female predominance. Mm-hmm. And that's what you're seeing in your practice.
Yes, we have very few males, and young or old.
Okay. And now they talk about lupus has a higher incidence in African American, Hispanic, Native American, Pacific Islander, and Asian individuals, much more so than Caucasian or white individuals.
Very true, and that includes adult demographics as well.
And we don't yet, from what I've read, we don't know why.
We do not know why. I'm sure there's some kind of, associated gene we just haven't identified.
Okay. And with aggressive treatment, they say the 5-year survival rate for pediatric lupus approaches 100%, whereas the 10-year survival rate is about 86%. And that sounds right.
Yes, I would agree.
So moving into the pathophysiology, I only have two things written down because this was rather complex, and I wrote down what I thought we should know. And I wrote down that 10% of patients with lupus have a first-degree relative who has lupus, and affected patients are more likely to have a family member who has an autoimmune disease.
So I think those statistics are true for most autoimmunity in some ways. It's not directly inherited, but you often will see some family history. If there's many people who have true lupus, then I'd be more concerned about lupus, but it's not by any means directly inherited.
So if we're seeing a patient in the hospital with a multi-system something going on, high inflammatory markers, that family history here is going to be key. Because if mom and aunt have lupus, we're going to think more about lupus. But if they have Crohn's disease and maybe celiac and then someone's got thyroid, it should be in our mind.
Yes.
Okay. And now I did write down the HLA class 2 alleles, DR2 and DR3. They say contribute to disease susceptibility in some patients, as do inherited complement deficiencies. And that's really all I wrote about that.
Right, so those are kind of board questions. The complement deficiencies are definitely something to think about. In real life, we don't typically send those HLA testing to prove it. It's more, at this point, academic. But complement deficiencies definitely would want to be thoughtful.
Okay. Now, for the clinical characteristics, we're going to get to the diagnostic criteria. In fact, let's start with diagnostic criteria, because then we'll get into the clinical characteristics. Now, I saw there was two criteria. The American College of Rheumatology criteria for lupus diagnosis. Looks like it was last revised in 1997. And then the SLICC criteria for lupus. That was updated last in 2012. What do we use?
So these original ones from 82 and updated 97, they're more for research.
Okay.
So we look at them, but they are not officially diagnostic criteria. So they are more as guidelines. They were used in research. We think about them a lot in lupus, but they're not like an official, you have to meet these criteria.
So what do you use?
So we look at them and we think about them.
Okay.
But I don't want them to be thought of as official diagnostic criteria. So we definitely think the newer
SLICC
is better because the original criteria had many things that were just rashes, like three criteria rashes, and ANA and immunologic disorder were separated. So it's not the best for diagnosis.
And for those of you listening at home, if you're not sure what we're talking about, so there are 11 categories in the 1982 revised criteria for classification of lupus to diagnose it from the American College of Rheumatology. I'll read the 11, then I'll read a quick description of each. The 11 are malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, renal disorder, neurologic disorder, hematologic disorder, immunologic disorder, and anti-nuclear antibody. Quickly, for malar rash, it's what you would expect, the one that spares of nasolabial folds. A discoid rash is the erythematous raised patches with the keratotic scaling and follicular plugging. The photosensitivity is just what it is. Oral ulcers are observed by the physician. Arthritis, they make a point a couple times, which we're going to get to later on in the article, that it's non-erosive arthritis, which apparently is key, involving two or more peripheral joints, characterized by tenderness, swelling, or effusion. Serositis, which is pleuritis, and then you got pleuritic pain or rub heard by a physician, or it's pericarditis, documented by EKG. Renal disorder, which we're going to get to. Neurologic disorder, which we're also going to get to, but seizures is the big one, or psychosis, headache. We'll get to those in more detail later in the podcast. And then hematologic, we're going to get to. Immunologic, they talk about anti-double-stranded DNA, anti-Smith, and then ANA and then ANA they talk about later in terms of labs, and we will talk about this, I'm assuming, but ANA is one of those where if it's positive, it doesn't tell you much, because a lot of people can be positive who don't have lupus. If it's negative, the article really talks about kind of thinking lupus can't be it if you have an ANA that's negative.
So an ANA, like you said, is nonspecific when it's positive. When it is negative, it's much stronger against lupus, but it's not perfect.
Okay. So did you have the SLICC
Yes.
criteria? Okay.
Yes, because I think that these are a better set of criteria. They're easily found on the web.
Okay.
But they break things down to look at all things like constitutional symptoms count, which is important because many things in autoimmunity have constitutional symptoms like fever, weight loss. So that helps you know that someone's inflamed and ill. So cutaneous includes not only the rashes we think about, that malar butterfly rash or the discoid rash, but also includes the non-scarring alopecia and the oral ulcers. Talks about all the same features like arthritis, neurologic, but it breaks it down because, for example, headache can be almost because of anything. But in a teenage female who has a chronic illness and doesn't feel well, it can be just a headache that way, or it can be because of lupus cerebritis. So it's important to consider all neurologic symptoms and try to get more information about them to understand where it's coming from.
So it's interesting because the article really talks about the first criteria, but you're saying in practice, rheumatologists are using the SLICC criteria.
Yes.
Oh, I wish they would have mentioned it then. Well, this article is a few years old, 2012,
Yes.
so maybe things have changed since then.
Mm-hmm.
So then let's talk about the clinical characteristics. So what they talk about is lupus being a periodic illness. So that means the symptoms are going to wax and wane, which means often there's a delay in diagnosis. So what they say is the time from the onset of symptoms to diagnosis ranges from a month to 3.3 years, with the median time about 4 months. And that each patient will present differently. No two lupus patients present the same.
That is super important to remember.
Is that so? And you're seeing, well, by the time patients get to you, they've probably gone through doctors and testing, and it's been a little while. Have you seen patients where it takes years to diagnose?
I have, but that's less frequent now. I think people are more thoughtful about it, and I think people are more likely to refer if there's rheumatology in the community. So we've been an established practice for a long time, so I think people know to send people earlier.
Okay.
But there are plenty of areas where there's not a peds rheumatologist, and it might take a long time.
Okay. And then they discuss differentiating lupus from acute rheumatic fever as a part of your differential. And they even say, they give you a little help. Patients with acute rheumatic fever, they have the erythema marginatum rash, and that's that pink rings on the torso and the inner surface of the limbs, which will come and go. And that really differentiates that disease. That's one of the things that can help you from lupus, which was nice, I thought.
Mm-hmm.
And then we talked about the diagnostic criteria. We talked about what you use. And in the article, table 1 is the ACR criteria. And I don't know what their boards are going to test us on, whether it's SLICC or the ACR criteria. That's what they have in the Peds Review article for table 1. And then the article then goes through and describes each of the potential areas of involvement for lupus. So they have all of them. So the bigger areas, mucocutaneous involvement, musculoskeletal involvement, renal involvement's huge, neuropsychiatric involvement, hematologic, pulmonary, cardiac, GI, and endocrine. At the end, they talk about neonatal lupus and drug-induced lupus. We're going to touch on neonatal, but we're going to kind of ignore drug-induced. So what I thought we could do, Elaine, if you're okay, I've kind of outlined the major areas and what's important, what I felt was important. I'll read one area at a time, and then you let us know if I've misinterpreted what they said. Maybe there's more to it than what I thought, and then we can hit on the entire thing. So the biggest section by far in terms of length is the mucocutaneous involvement and renal involvement. So mucocutaneous involvement, we'll start with that. They say you have some features of mucocutaneous features in lupus in 90% of patients. Almost everyone's going to have something.
I would totally agree with that statement.
And they say malar or the butterfly rash is the most common, and it's the hallmark of the disease. And you can see a similar rash, they reminded us, in dermatomyositis. But in dermatomyositis, you have Gottron's papules on the metacarpal phalangeal and interpharyngeal joints, along with elbows and knees, which you really don't see in lupus to help distinguish them.
That is one truth. Also, when you do have a malar type rash in dermatomyositis, it tends to not spare the nasolabial folds.
Oh. So,
and then lupus rash can occur on the fingers, but it tends to be between the joints, the exact opposite what you see in dermatomyositis.
Oh, and that's fantastic. I did not know that.
The other thing, the malar rash tends to be photosensitive, so will be, started after sun exposure. It tends to be a real rash, just not like a flushing. Tends to be raised and scaly and last.
Okay.
Because people get referred a lot for rosy cheeks when they work out, so there's a big difference between like a true rash and just like flushing.
So it's not something that's going to come and go. It's going to be there. If it's a malar, it's going to last for a while.
Tends to, and definitely sensitive to the sun in most individuals.
So a person going out, though, it'll look a lot worse when they come in from the beach or from going outside.
Yes.
And then they talk about discoid lupus, so named after its coin shape, an erythematous rash that primarily affects the face, ears, and scalp, although the upper chest and upper extremities and back could be affected. And the rash can scale or crust and can scar. And the central area is hypopigmented, or can be. And they say it's interestingly, it may manifest as a feature of a systemic disease where it can be an isolated finding.
Yeah, so some people have isolated cutaneous lupus, and it could be discoid. But some people have discoid in the setting of systemic lupus.
And then they say that only about 5% of patients who have isolated discoid lupus will progress to full-blown symptoms. So if that's all they have, that they're in pretty good shape.
That is true.
Well, that's great.
So discoid lupus we tend to be aggressive with because it will scar.
Is that right?
And especially if you have a darker pigmented skin, then the scarring's worse because not only do you have a scar, but then the color is different. Okay. And so it's more visible.
So you're more aggressive in treating that.
Yes.
And then they recommend anyone with lupus has to wear sunscreen with an SPF of a greater than 30 year-round, irrespective of what's going on outside, to prevent development of rash and systemic disease flares, even if they don't have a rash.
That is true. So we know that sun exposure increases cell turnover, which then increases your risk of seeing your own self-antigens, which will lead to a flare of lupus, whether or not you get it just a rash or you just get fatigue or other symptoms.
So a hat, cover up, SPF 30 or greater than 30.
Yes.
And this article talks about hydroxychloroquine, which at the time of writing was one of the 4 drugs approved for treatment of lupus by the FDA, and it's a mainstay of therapy. Is that still true?
That is true. So the brand name's Plaquenil.
Okay.
It's anti-malarial, but we know that it's super important for lupus. So almost every individual with lupus will be on it for the long term.
Okay.
It does many, many things. Skin is a really important part of its use, but it also helps with fatigue, arthralgia. We think it prevents flares. So it's a very, very important treatment.
Okay. And they talk about the major complications of it is retinal toxicity. So the patients have to be screened by an ophthalmologist at baseline, then every 6 to 12 months.
That is true. So that is the biggest limitation to this drug's use. With us knowing drug ranges, we've seen much less of that.
Okay.
So they've even changed it again. This paper lists 6.5 mg per kg per day,
Mm-hmm.
but it's been decreased to 5 mg per kg per day.
Ooh.
So you'll see people having their doses adjusted over time, but we really feel that's a threshold where you really reduce that risk.
Okay. Other treatment for rashes with lupus includes systemic corticosteroids, and they talk about belimumab, which I'm going to always mispronounce these antibodies.
We also call it Benlysta, so it's easier to call it Benlysta. Benlysta is the brand name. So that drug has not been used as commonly in pediatrics because it was initially approved for adults. So adults are using it a lot. Okay. We're only starting to use it more in our practices.
Now they go through and mention vasculitic rashes, palatial ulcerations, Raynaud's phenomenon. Just as a reminder for those of you at home, we're going to take boards at some point here. Remember the classic triphasic color change for Raynaud's, blue and white, and then on rewarming red of the hands, feet, and sometimes ears and nose. And there may be associated tingling or burning with that. Does that sound right?
Yeah, so Raynaud's is pretty much limited to toes and fingers.
Okay.
Tips of the nose, chin, tongue even can affect nipples, but it tends to be very distal, so it's not the whole hand. And although Raynaud's can be seen in lupus, if you have significant Raynaud's, we might think that you have overlap with another autoimmune disease.
So more than one.
Right. So some people have mixed connective tissue disease, which is an overlap of several, or even scleroderma, or some people don't even fit in any category.
Okay. And they have a table 2 in this paper. The table 2 is great. It goes through the clinical characteristics of patients who have lupus, and it goes through every organ system involvement, and then a percentage at diagnosis and a percentage within 1 year, how many people, and it just kind of lists everything, which I found to be helpful. I mean, and at the bottom, it talks about the autoantibodies, anti-double-stranded DNA, anti-Smith, which we're going to get to, rheumatoid factor. So I like that. I mean, it just kind of walked through it all. Now, we're going to keep going because there's more to do, but I did like that table for those of you at home. It was good.
Right. I think it's a nice table in that it tells you that, yes, a significant proportion of people will have these, but there's still a number who won't. So that's why lupus can be so variable in its clinical presentation, because even though most people have rash, some will not. So you have to be very thoughtful about considering it.
Yeah, that's it. Because for those of you at home, it's an entire page, the table. It's huge. And so people can, kids, I'm assuming, mix and match for what they have and don't have, which makes it, I guess, the hardest. It's one of those ones we always think about for just about everything. This patient's coming in, they're a little fatigued, maybe their ESR is up. Lupus is a possibility. It's always a possibility.
That is exactly right. But that's why we get so many positive ANAs, because it's thought about and people think that an ANA itself diagnoses it.
Right.
But that is not true. So Need more than just the ANA.
What I have towards the end is a list of what I would send if you all weren't here. If I was thinking this patient may have lupus, we'll go see how it did.
That sounds good.
Now, one of the things they also talk about is alopecia. They say that alopecia may be one of the presenting manifestations of lupus. It classic occurs in the frontal area, but it can be diffuse. And as kids get treated for their lupus, the hair can regrow. I did not know that. That's true. So a child with alopecia in the frontal area especially, that really should make us think about lupus.
So diffuse. It's not like what you see in alopecia areata, alopecia universalis. Okay. So it's not going to be large, just plain, like circles on the scalp like you would see in those conditions. And when they say frontal, it means like a diffuse, more in the front than the back. And I can't say that I've seen that in clinical practice, although they're reporting that.
Okay. Now, musculoskeletal involvement. Now, how do we do with the first one we did was mucocutaneous? How do we do?
I think good. We got a good cover of it.
All right, good. Now, musculoskeletal involvement. Arthralgia and arthritis are very common in lupus. And interestingly, and unlike other causes of arthritis, like we talked about, the lupus arthritis is usually non-erosive. And these are often symmetric involvement of both the large and small joints. They say primarily knees, wrists, ankles, and fingers. Does that sound good?
That does. So you can just have arthralgia without overt signs of arthritis, but it tends to be inflammatory arthralgia where it'll be stiff in the morning, feel like they can't use it, but they might not have super huge swelling like you would see in other forms of arthritis.
Oh, that's great. Lupus patients can develop an unusual type of arthritis they mentioned called Jacquard arthropathy. I hope I'm saying that right.
Yes.
Now, I had not heard of that. So for those of you who are at home saying, what is that? I didn't know what that was. You're not alone. I didn't know what that was either. But they say it's an ulnar deviation of the second and the fifth fingers and subluxation of the metacarpal phalangeal joints. Do you see that?
Not typically in kids. It's more something you'll see in the adults.
Okay. All right.
The thing is about it, it's reducible. So it looks like they have a lot of affected, but you can reduce it. Back. That's the thing about this type of arthritis. It's not as destructive as juvenile or rheumatoid arthritis.
Well, that's good for them.
Yes.
And myalgia and myositis, they say, can also occur. And they talk about treatment for the symptoms as per the article. They say NSAIDs are the first line for the musculoskeletal treatment of these lupus of lupus patients. Is that what you guys use?
As long as you do not have renal involvement, yes.
Okay.
Or platelet problems, but we can talk about that later.
Okay. And the hydroxychloroquine as well, and then it helps with this as well.
Yes. And so how we treat things like lupus really depend on your manifestations. So if you have a lot of arthritis, you might be treated similarly to juvenile arthritis, but if you have, in some ways, but if you have other major manifestations of arthritis, then will be often managed by those same drugs that treat.
Oh, I see. So if you're using like a cyclophosphamide for the because there's significant renal involvement, well, that's going to help the arthritis, arthralgias, the skin anyway, so you're fine with just that.
That's correct.
So you treat the worst symptom.
Yes.
Okay. Well, that's not so. Renal involvement's the next one.
All right. Let's talk about it.
So they said this is the greatest contributor to morbidity and mortality in the pediatric lupus population.
That is true. So more kids have renal involvement than the adults do when you're looking in comparison.
Is that right?
Yes.
And then up to 65% of patients with pediatric lupus have renal involvement. They usually get it in the first year of diagnosis. And it can manifest in lots of ways, but some of them is proteinuria, microscopic hematuria, hypertension, elevated BUN creatinine levels, and even 18% of kids may develop nephrotic syndrome.
That's correct. There's a form of lupus nephritis that is presentation is nephrotic syndrome.
So now let's get into the forms. You're really leading me along. This is great. So one of the things they talk about, a way to screen for if you have active renal disease is to spot first morning urine to protein creatinine ratio. What they can have in their urine is everything from active urine sediment like red blood cells, white blood cells, cellular and granular casts. There can also be low complement levels, elevated anti-double-stranded DNA levels, which from what I have read, those anti-double-stranded DNA can be used to help diagnose, but they're also used to track disease progression, how well your treatment's going.
That is correct. That's the only antibody that's able to do that.
Yeah, that's what I've read. The anti-Ro, others they cannot. They can help tell you if you have it, but they can't tell you how well you're doing with treating it.
That's correct.
And proteinuria, and they recommend a renal biopsy to help really differentiate the classes. And again, if you're listening at home, there is 6 classes of renal involvement in these lupus patients. They are on that table 2 we talked about. So we're going to talk about them a little bit. The next part of this goes into differentiating and delineating the type of renal involvement. from the least concerning, which is mesangial lupus nephritis. That's class 1. That's the mildest. And they say some of those patients don't need to be on any medications. They may actually be a little hard to diagnose. To class 4, which is diffuse lupus nephritis, that's the most common and most severe type of lupus nephritis. And they say class 3, so let's start with my first one here. For some reason I have class 3. It's focal lupus nephritis. That affects 41% of patients with pediatric lupus, often presents as hematuria and proteinuria. Mesangial class 1, that's the mildest form we talked about. They can have a normal UA, normal creatinine. Class 4, diffuse lupus nephritis, most common, most severe, affects about 65% of the patients who have renal issues with lupus, can present hematuria, proteinuria, hypertension, have low C3 and C4, and elevated anti-double-stranded DNA levels and proteinuria. This is where they really want that first morning protein spot urine to protein ratio. And then they talk about getting a biopsy if you think that's what this is. Does that sound right?
Right. We will biopsy most people who have lupus nephritis just so we know
which one it is.
If
So there's protein in the urine. If you have an elevated morning protein spot, urine protein to creatinine ratio, you're going to biopsy that kid.
Most often.
Okay. And then they say that most rheumatologists, and I have a rheumatologist here, and nephrologists would treat patients with class 3 and 4 disease aggressively for new lupus nephritis with either high-dose corticosteroids, which is a 2 mg per kg, or IV pulse methylprednisolone plus potent immunosuppressive agents.
That is true, but their choice of immunosuppressive agents is not what most people would do at this.
So they talk about cyclophosphamide. So you're saying that's not what people would...
Not anymore.
Okay.
So when I was a fellow, that is what we use, but now most individuals do really well with mycophenolate.
Is that right?
Yes.
Mycophenolate mofetil.
Yes. So that would be our go-to. There are still some who may get cyclophosphamide depending on your other manifestations, but that is not the first line anymore.
Oh, that's great. Now, they talk about cyclophosphamide for those of you at home. What I'm going to go through quickly is the side effects of cyclophosphamide, just in case that's somehow asked on our boards. We're here. Bone marrow suppression, alopecia, infection, malignancy, and infertility. And they talk about the risk of gonadal failure is dose dependent. So some physicians who have post-pubertal females will use leuprolide acetate to suppress oogenesis, which then prevents damage caused by cyclophosphamide to dividing cells, which lessens the risk of infertility. And for men, boys, you're just sperm banking and hoping for the best.
That is true.
Okay.
We do carefully monitor dosing and we limit dosing. So the infertility risk was a little less than we thought in the past, but we still do all these things.
That's great. So then they talk about hypertension with the lupus nephritis, and then one of the things they talk about in the end for PCPs in the outpatient office, but it can also be for us if we're managing for some reason, if we're at a center where we don't have pediatric rheumatologists, you all are not a dime a dozen, so not every center has one, to always check blood pressure.
That is correct.
Because they want to aggressively monitor and treat hypertension that can come up with these patients.
That is true. And you can have hypertension not only because of renal disease, but because of high-dose steroids.
Oh, that's fair.
So there's lots of different reasons that a person with lupus may need their blood pressure
All right.
controlled or monitored.
And then the last one, class 5 that I have here, membranous lupus nephritis. That's 29% of lupus kidney issues. These kids will commonly present with nephrotic syndrome, which may occur alone or in combination with other types of nephritis. And at time, proteinuria can be very significant, more than 5 grams per day.
That is true. And we have several patients in our practice who presented just with nephrotic syndrome, not one other symptom, and no one thought of lupus until their biopsy showed what you would see in lupus.
Is that right?
So that has to be on your differential of nephrotic syndrome.
So if you have a kid presenting with initial onset nephrotic syndrome, you should really consider lupus.
It has to be in there. I mean, there's still going to be all those other things,
Right.
strep and,
Membranous nephritis, all that stuff.
rapidly progressive, all those things. So you still need your nephrologist, but don't forget about lupus.
Okay. So that's the nephritic section, or the lupus kidney section. How do we do there?
I think we covered what everyone needs to know. So a good chemistry, urinalysis, and blood pressure are going to be your first tools in determining if you're worried about that for a lupus patient.
That's great. Now let's hit neuropsychiatric. And this occurs in 2/3 of patients with lupus, presents with the first year diagnosis typically. It's the second leading cause of morbidity and mortality. Highest percentage of neuropsychiatric involvement is manifestation as a headache. And then other symptoms can be decreased concentration, cognitive dysfunction, psychosis, seizures, transverse myelitis, CNS vasculitis, or stroke. And what's interesting is they mention that one of the rules of thumb they have is lupus-induced headaches. So the headaches from lupus cerebritis, let's say, they're not responsive to non-narcotic analgesia. So your NSAIDs aren't really going to do anything.
That's true.
And so that's one way to think about if this kid's headache is not really getting at all better with what you expect it to maybe lupus pop up in your mind.
That's true.
And what they say is treat the underlying lupus with high-dose steroids, immunosuppression, or mycophenolate mofetil, they mention it for here, and then the neuropsychiatric symptoms improve.
Right, and we also would use rituximab in this instance instead of cyclophosphamide as much, but you still might use cyclophosphamide depending on the presentation. The important thing to think about in neuropsychiatric too is you're always ruling out infection. For example, these kids are immunosuppressed on high-dose steroids, and now they have a new onset headache. You have to think about, could this still be meningitis? Right. So you have to be more careful about, do I need a lumbar puncture or not? Do I need, imaging or not? Because you have to think of them in two ways.
And it's interesting because we recently had a patient, and I'll give a lot of details for HIPAA, obviously, that fit the demographic category for lupus and presented with just auditory and visual hallucinations as part of our screening, because it was the first presentation ever, never told anybody. There was an anti-CCP and rheumatoid factor done, and the anti-CCP was very positive. And that was really, then after second time we brought him back in, because that took a day or two to come back, and he was doing fine, we sent him home. When he came back in, he then said, I have some muscle aches and pains, and maybe some arthralgia, but really that can be your only presenting symptom. It's rare, though.
That's true.
That's fascinating. All right, so that's neuropsychiatric. How do we do?
I think the neuropsychiatric is the most nebulous because there's so many different reasons to have depression and headaches.
Yeah.
So you really have to consider it and think about it.
Now, I would assume, and I don't give numbers, but stroke from lupus neuropsychiatric symptoms is extremely rare.
Not as much as you would think, but it's usually in individuals who also have lupus anticoagulant or antiphospholipid antibodies.
Okay.
So that's when it's way more common.
You're leading this so well because heme is next. That's fantastic. So more than 60% of patients with pediatric lupus will have a cytopenia. Leukopenia is usually secondary to lymphopenia, is found in 2/3 of patients, and can give you a clue towards a diagnosis.
That's my biggest pointer. When you're looking at a CBC, if you see lymphopenia in the right setting, that's a really strong marker for lupus.
So in these patients, we think of calling you on that there's just the odd, vague symptoms. If I see lymphopenia, that makes this a stronger case.
Yes, especially if it's persistent.
And you can also have anemia and thrombocytopenia, and that's found in 30% of patients.
Yeah, so when you see lymphopenia, thrombocytopenia, and some anemia, you definitely want to think about lupus.
Okay. And then they talk about patients presenting with idiopathic thrombocytopenia and Evans syndrome. And again, in case you forgot at home, that's Evans syndrome is an idiopathic thrombocytopenia and hemolytic anemia, especially an adolescent female. You should really consider lupus as the underlying cause.
That is especially correct, yes.
Okay. And then they go through antiphospholipid antibody syndrome and talk about that a little bit. They discuss that it can be primary or secondary to an underlying connective tissue disease like lupus. And they could talk about it can also cause thrombocytopenia, arterial or venous thrombosis, stroke, TIA, chorea, recurrent fetal loss or avascular necrosis. The lab values, because these patients are in a hypercoagulable state, and the lab values that would help you would be positive lupus anticoagulant, increased cardiolipin, and antiphospholipid antibodies, or a prolonged PTT. Does that sound right?
Right. So every lab is going to have a different panel, but you want to order lupus anticoagulant. That's traditionally that dilute Russell Viper venom time, which also then most labs will include that prolonged partial thromboplastin time. And then you also want to order anti-cardiolipin antibodies and anti-beta-2 glycoprotein antibodies.
Oh, we didn't have that. Anti-beta-2 glycoprotein?
Yes, so that all those together will help you because some people will not have the lupus anticoagulant, but they will have anti-cardiolipin or anti-beta-2, which is just as risky and still meaning that you have the antiphospholipid or lupus anticoagulant.
And if I see antiphospholipid antibody syndrome, I'm thinking this patient may be secondary to lupus.
That's correct. So you can have a primary where that's your only problem. Half of those will eventually probably have something like lupus, but half may not. And then it could just be secondary to lupus.
Okay. That's all I have for heme. Did you want to bring up anything else?
I think in terms of that antiphospholipid, they may or may not ever have a consequence of that. But if you have antiphospholipid antibodies and you have lupus and you're a female and you have other risk factors, smoking, pregnancy, birth control, those are all reasons to clot. So we're very careful to mitigate any of those other reasons. So if you have lupus, you're allowed to take estrogen birth control. Mm-hmm. But if you have lupus and antiphospholipid, you're not allowed to take estrogen birth control. You have to use other measures. And we counsel very carefully about making sure they get appropriate care if they're considering pregnancy. Really counsel about travel and smoking just to prevent any of those things.
So do you put your female patients who have lupus and antiphospholipid antibody, are they on anticoagulation?
So if they do not have a clot, we do often give aspirin. So That's controversial, but we feel that it's helpful in some ways. If they've ever had a clot, then we get help from hematology for long-term anticoagulation.
Okay. All right. So as a hospitalist, where this would strike me is if I see one of these patients and they got a clot, one of the things I'm going to think about is, should I screen for lupus to see if there's something else underlying here? And then should I get rheumatology involved? And if I'm at a center without rheumatology, I may call my local pediatric rheumatologist to get their advice on this.
That's true. You should definitely, it should be in the differential.
Okay. So next we have the lung. So there's not a whole lot here. So the lung, lupus's pulmonary involvement can include pleuritis, pleural effusion, pneumonitis, pulmonary hemorrhage, and pulmonary hypertension. Now again, if you're driving, you're exercising, you're saying, I forget what pleuritis is. Can you remind me? I have you covered. Pleuritis is the most common manifestation of lupus. The patients will complain of dyspnea and sharp stabbing chest pain during inspiration. And then what they say is if you do PFTs, they'll be abnormal and you should see a restrictive lung defect. And then any patient with pediatric lupus, and this is something I want to ask you, Elaine, who has acute shortness of breath and then a sudden drop in hemoglobin, you really got to consider pulmonary hemorrhage, which is rare, life-threatening complication of lupus, pediatric lupus, but you really need to think about this.
Very, very true. So there's very few rheumatic emergencies.
Right.
Like a swollen joint hurts, but it's not an emergency. But things like pulmonary hemorrhage, CNS vasculitis, those are all really, really important things. Obviously, clots in antiphospholipid syndrome. Those are emergencies.
If I have a patient who comes in with shortness of breath, who happens to have pediatric lupus, I need a hemoglobin. I need to think about potentially them having a clot. So maybe a D-dimer is relatively useless, but probably a CT angiogram looking for a clot in the lung if they're really short of breath. Of course, thinking about pneumonia and other stuff that can normally happen, but those are the odd life-threatening things that are more likely in these kids.
Yes, that's true.
All right. That's all I got for lungs. How do we do?
I think that's good. Pleuritis and pleural effusions are going to be way, way more common than anything else. Pneumonitis, much lower, and then pulmonary hypertension, pulmonary hemorrhage, much, much lower.
And then you're going to treat the pleuritis it would be resolved with the treatment of the lupus.
Correct.
So if they have renal involvement and you're using mycophenolate mofetil, then their pleuritis is going to get better.
Yes, and you can still have flares of different things. That's the hard part about managing so many different symptoms and systems. You may have the kidneys under good control, but they still could have a flare of a rash or arthritis or, pericarditis or pleuritis. So.
Okay. And for those of you at home, we're still in the same article, which is why it took me so long to prepare for this. So there is a lot. This is a very dense article. It's got a lot there. I was happy to go through it because my hope is on the boards I'll get these lupus questions right. We'll see. Next, we're going into the heart. We are leading right one. It's perfect the way we're segueing here. So lupus patients are at increased risk for pericarditis, pericardial effusion, myocarditis, Liebman-Sachs endocarditis, bacterial endocarditis, and premature atherosclerosis. Now, they say that pericarditis and pericardial effusion the most common cardiac complications in pediatric lupus.
That is very true.
And then often they're a cause of a recurrent chest pain in lupus patients.
Yes.
Okay.
But you can see how difficult it is to assess chest pain because you have so many different reasons to have inflammation that isn't that dangerous all the way up to overt clot or...
Well, that's what they talk. They go through a couple of paragraphs talking about in the cardiac section about how much it's important to know that these kids will have early onset atherosclerosis. So good nutrition, exercise, stress that. And then that brought up my question, which would be, if I have a lupus patient who comes in with chest pain, I may be doing just about everything, almost like an adult, because I'm med-peds trained. Yes. I'm ruling out MI because they have early atherosclerosis, and it can be an MI.
completely can be an MI.
If they're short of breath at all, I'm thinking maybe this is the lung. There's a PE there causing chest pain and causing shortness of breath, or I have to get an EKG. Maybe I'm thinking about pericardial effusion or a pericardial rub or something. So it's really, your differential drastically changes with these kids when they come in for what could be a common complaint.
That is very true. So they're much more difficult to triage over the phone. So often we'll send people to the ER more than you would a kid with another condition, just because of the huge differential and the risk of not catching some of these disorders.
That's amazing. So for pericarditis, as a quick reminder, that's going to present as anterior chest pain and dyspnea that worsens when you lie flat. And they say, like with other causes, that can be treated with NSAIDs and mild steroids or more if you need.
For example, this is a place where we might use anakinra for anyone out there. It's also called Kineret. It blocks IL-1, so we use that a lot because you can use it just acutely and you're trying to spare steroids in many individuals. So that's a good use of that.
Now, for these patients, are you really focusing, sending them to nutritionists, getting them to exercise to try to minimize these risks when you're seeing them as an outpatient?
We definitely try. It's hard because you're dealing with so many systems, so many medicines in very complex kids. So we probably need to do more than that, but you're worried about, are you seeing the eye doctor?
That's true.
Are you?
Are you going to the nephrologist? Let's say you take a look at your urine. There's a lot going on.
Yes.
These are complex kids.
Very complex.
Now, the next two systems are quick, GI and endocrine. So GI, a third of the patients with pediatric lupus will have some GI symptoms that'll primarily manifest as serositis, vasculitis, pancreatitis, or enteritis. Abdominal pain is the primary complaint. And most patients who have lupus, I didn't know this, they say will have functional asplenia. So that means they're at risk for sepsis from strep pneumo and other encapsulated bacteria. Is that right?
That is true.
That's interesting. That's not one of the things I usually think about for functional asplenia. And is that after a number of years of diagnosis, or when they're a little older, you'll just assume it's functional asplenia?
I think right off the bat, you're worried about them in terms of infection, not only because of the underlying immune dysfunction, but because you have them on a lot of immunosuppression, because this is a very serious illness.
So these kids, if they get a fever, they're getting antibiotics. And those kids, you're sending them to the hospital to get
They're getting evaluated. It depends on the symptom course for sure, but yes.
All right. And endocrine is very short. They really talk about hypothyroidism is very common in lupus. And that delayed puberty is common as well. Irregular menses are common, especially during periods of active disease. So do you screen everyone for thyroid disease?
Yes.
Is it like an annual screen if they pass?
I can't say that we would do it annually, more with symptoms, but definitely at onset, because we want to understand the full biochemical profile of the individual and see what we're dealing with. Really symptomatic.
So again, someone coming in with lupus who doesn't have hypothyroidism who has odd symptoms, I may do that then.
Yes.
I might send TSH and free T4.
Yes.
So here's the exciting part, the lab section.
Woo!
All right, so this is, after all of my reading, this is what I would do. I will tell you what you would think. What you think? If I have a patient who I suspect has lupus and I'm in the hospital, I'm going to send a comprehensive metabolic panel. For those of you at home, if you have something different, that's where you have the electrolytes, beta-creatinine, and the LFTs, the total bili, and the albumin. I'm going to send a CBC with differential. I'm going to send an ESR and CRP. I'm going to send an ANA, but I'm also sending an anti-double-stranded DNA antibody and a UA with a C3 and C4.
You're doing so well. I'm really impressed.
All right.
Yes. So it's really, really important to look at kidney and liver function. It's important to look at the entire differential and platelets. We send an ESR and CRP because it helps us differentiate what's going on, because you can have a lupus flare because you're infected. So a CRP helps a lot, because many times, even if you're in a lupus flare alone, the CRP may be normal despite a very high SED rate. But if you have an infection on top, the CRP can be high. ANA is important, but the specific ANAs like the double-stranded are even more important. So if you're working them up for the first time, you're going to send more antibodies. If you know they have a double-stranded DNA, you would send that in an acute flare or infection.
And the ANA does that change with acute flares? The ANA with the concentrations of just?
The ANA is kind of like you have it or you don't. We do look at titers and patterns, but those aren't as important. So we send it when we first are concerned to meet somebody. We wouldn't send it every time, but it might be something that you do in the future if they have new symptoms, or some places do panels where if you send it ANA and it's positive, it automatically does a specific panel of antibodies, and that might be the way you order it. But otherwise, you just want to know specific antibodies, which we may talk about soon.
I think so. Okay. And then they say CRP can remain normal in pediatric lupus, but these levels can increase during active infection or flares.
That's true, because you're always if you have lupus and you have a fever and a rash, is it your lupus or do you have an infection? Because you're going to treat them slightly differently. You might have to treat their lupus, but you might have to cover them for an infection while you're, increasing their treatment for lupus.
So now, anti-Smith antibody, they talk about being highly specific for lupus and may be found in up to 50% of patients, but again, it's not good for disease activity.
That is correct.
And then there's a list of anti-ribonucleoprotein antibody, anti-Ro, anti-La. And they talk about them somewhat here in the article, but I took away that they're not the most exciting ones to send. But is that true?
So, unfortunately, in lupus, not everyone's going to have a specific antibody. So you can still have lupus and not have double-stranded Smith, Ro, La, or any of those. So that's when the ANA does help you, because along with all these other abnormalities. So every person that we think has lupus or a related disorder will get that whole complement of
everything.
Yes. So you'll send the double-stranded, you'll send the Smith. Anti-ribonucleoprotein is also called anti-RNP. Ro and La are also called SSA and SSB. Those are the ones that can be associated with Sjogren's. And then there's some others, depending. If you're not sure that they're lupus, you might send some antibodies that are seen more in things like scleroderma, so SCL70, etc. So RNP can also be seen in mixed connective tissue disease. So you can have it in lupus, but you also might have mixed connective tissue disease. So there's a lot of intricacies in understanding the antibody profiles.
So if I'm sending all this, I'm sending a patient to you.
We would want that, yes.
Okay. Well, now we're going to hit neonatal lupus and go on to the next article that we have. But that wraps up what I've reviewed. How did we do?
I think that's a really good overview of lupus. I think the bottom line is lupus can almost look like anything. And I've seen individuals who are a little tired and get a rash in the sun. And I've seen individuals who have had strokes and their kidney failure in the ICU and everything in between. So lupus can be very, very serious, but it doesn't have to be. And with good monitoring, many kids live normal lives.
All right. Now, neonatal lupus is not a disease I'm very familiar with, but what they say is it occurs in 1% of infants who experience transplacental passage of maternal SSA or SSB antibodies.
Right, and I think maybe more like 2%. It depends on your source, and that's just in the general population.
Of people. And they say the most common manifestations are rash, cytopenias, hepatitis, and hepatomegaly.
Yes. So I think rash is the one most people will notice. And the big thing about the rash is photosensitive. So the baby goes to siblings' soccer game at 4 months or 4 weeks old, and then you get the rash. The rash can be misdiagnosed because you're a baby, you have this rash. So it can
think it's like a newborn rash.
Right, or eczema or ringworm because it can have raised borders, and it's on the scalp and the face. So
the areas that are exposed to the sun primarily in an infant, you're going to cover up everything else.
Yes.
And is there a time period you'll typically see these kids?
Right, so it doesn't usually start at birth, but many kids will have it before a month, but usually in the first couple months.
And they say the most concerning complication for them is congenital heart block from antibody-mediated damage to the cardiac conducting system. And it can be seen in up to 30% of patients infants who are born with neonatal lupus. So a smaller population already, but 30% of them can have it.
Yes.
And then they say fetal bradycardia can be the first sign of neonatal lupus. Mothers can be evaluated at 16 weeks gestation.
Yeah, so it starts early, so you want to catch it. So they, it usually happens, I want to say, around 18 weeks, but they like you to be screened starting at 16 weeks. That way you catch it.
And if you see the fetal bradycardia and you think that's what it is, the treatment is the mother taking dexamethasone as soon as it's identified to decrease heart block and decrease maternal antibodies and inflammation in the conducting system.
Some may do that. Some may also give IVIG. We do not have any perfect treatments. Every woman that we know has this risk will be on Plaquenil or hydroxychloroquine. Because there are some studies that say that is helpful. It's not perfect, but it's something that they're on anyway, and it's helpful for their lupus, but it doesn't hurt the baby, and if anything, it protects them.
So now if I see a kid within a month, an infant, photosensitive rash, scaly, primarily in areas of the sun, and if they have any cytopenias, hepatitis, or hepatomegaly, I'm really thinking neonatal lupus.
That is true. The rash also has a predilection for around the eyes, so they kind of have a raccoon mask. So that's another thing that you might notice.
Oh, that's great. Now, we are done with that Peds in Review article. For those of you at home, that was almost an hour on just that article. And I've rarely done that, but this was a very dense, I thought it was great. I really liked how it was written. I thought it was extremely thorough. especially for someone like a hospitalist or general pediatrician or someone not in rheumatology. I feel like that's a great review.
That's exactly what you need, because you have to know enough to recognize it and know how to start the workup and know what to be worried about.
So now next we're going to talk about an article, Outcomes in Hospitalized Peds Patients with Lupus, written by Mary Beth F. Sun, Victor Johnson, Amy Hers, Mindy Lowe, Karen Kostenbader. It was in Pediatrics in 2014, volume 133. They started out in this article discussing how the incidence, severity, and outcomes of adults with lupus are well known. It's worse in women, minorities, those without medical insurance, those with lower socioeconomic status, and are at risk for developing, their increased risk for developing disease and poor outcomes. They discuss how this really hasn't been flushed out as well in pediatric patients with lupus. They think there's some preliminary stuff before this article is written saying the same exists for pediatric lupus, but they decided to do this study to look at that. So they used the FIS database, another FIS database study, and they used that to examine the association of socio-demographic features and volume of admission per hospital with outcomes, including ICU admissions, end-stage renal disease, and in-hospital mortality. They did a retrospective analysis from January 1st, 2006 to September 30th, 2011, roughly 5 years, and they looked at kids who were at age 3 to less than 18 years old. And they ended up looking at over 10,000 admissions. And they did a multivariate analysis, and they did all this stuff, but I'll tell you what they found. Elaine, you tell me if you agree. They found that, number one, Hispanic children had longer length of stay, more readmissions, longer ICU stays, higher severity of illness indices, and higher in-hospital mortality compared with non-Hispanic children. And that was across the board. They found that African American race in their multivariate analysis was associated with ICU admissions, and they found that African American race and Hispanic ethnicity alone was associated with developing end-stage renal disease or dying.
So I think that those statistics represent what we have recognized in the past, that certain ethnic groups have more severe disease. So they're known to have more renal, more neuro involvement. So that would mean that the kids you're seeing in the ICU are most likely of those ethnic groups.
Okay, and it's similar to what they found on the adult side. Now everyone's obviously rooting that it wasn't the same in pediatrics, but unfortunately it is. And the hospital characteristics they recorded, what they said was that the hospital itself, the location, the volume of lupus patients seen, those were not associated with outcomes. Meaning, if you're at a high center with millions of lupus patients everywhere versus another center, that really didn't affect their outcome of the patient. Which I thought, I guess there's not a ton of pediatric lupus patients anywhere, so I guess it really wasn't that surprising, but I figured they'd be a little bit better with the bigger centers like ours.
Right. So I think, because we're actually not a huge center for lupus because of the ethnic groups in our region.
That makes
so
sense.
We probably have about 70 lupus patients in our entire practice,
Okay.
as opposed to maybe a center in a different area.
Okay. Well, and that's what I thought were the high points. Is there anything about that article you want to discuss?
No, I think that's true. Shortly we'd like to know more about what are some of the factors, and someday we'll have more about genetics, and we can maybe have some better conclusions and maybe ways to prevent it. But I think it just represents what we kind of already know in terms of who gets sicker with lupus.
Well, that's everything I had. Elaine, I thought this was great. I'm glad I reviewed it. I was not comfortable with lupus as much as I am now. You're our expert guest. Any final words?
I think that it's really just important to review these topics here and there, because you're going to see lupus. Lupus is 1 in 1,000 kids maybe, or 100,000 kids, I'm sorry. So you really need to think about it so you don't miss it, and then you help that child and their family have a healthy life.
All right. Well, Elaine, I want to say thank you very much for coming. I really enjoyed this. I really appreciate your time.
Thank you so much for having me.
All right, everyone. Let's do our recap and our acknowledgement. So thank you to UPMC Children's Hospital Pittsburgh. Thank you to the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast, our Division of Rheumatology. Thank you to the University of Pittsburgh, who continue to give us the free CME credit and support the podcast. Again, just click on the link at the bottom of the podcast, and you can get free AMA Category 1 CME credit with any of our medical education podcasts. Thank you to Dr. Megan Keene Tarchichi, who always helps me with everything. I want to thank all of you who are listening. I really appreciate your time. I really appreciate you all listening in on us, whether you're walking or driving or wherever you are. We hope you like it. As always, I'm happy to get emails, and my email address is tony.tarchichi, tarchichi at chp.edu. Feel free to email me with concerns, questions, topics you'd like us to cover, compliments, whatever you want to do. Thanks again, everyone. Have a great day. We'll see you next time.
Thank